All right, welcome to this rapid fire explainer. I'm going to be your professor today, and we are diving straight into the absolute highest yield pharmacological concepts for your long answer questions on smoking cessation. If you're prepping for exams, or honestly, if you just want a rock solid, evidence-based breakdown of exactly how we treat nicotine addiction, you are in the perfect place. So grab your notes, get comfortable, and let's jump right in. Here is our game plan for today. We'll start with nicotine addiction and pathophysiology. Then we'll cover nicotine replacement therapy, followed by the non-nicotinic therapies. After that, we'll look at overall cessation strategy, and we'll wrap the whole thing up with a master table loaded with exam pearls. So let's kick things off with a foundational question. It's one that examiners absolutely love to ask in vivas. Why is quitting notoriously so hard? And what exactly are our drugs doing to help? Well, to understand the cure, we really have to understand the disease first. Nicotine creates chronic, hardcore physical and psychological dependence. When a patient tries to quit cold turkey, they're slammed with a brutal withdrawal syndrome. We're talking intense craving, irritability, serious anxiety, and insomnia. Our pharmacological treatments essentially act as a bridge to mitigate all of that chaos. Now, listen closely to this mechanism because examiners practically drool over this stuff. Nicotine literally hijacks the brain's reward center. Specifically, it activates the mesolimbic dopaminergic pathway running straight from the ventral tegmental area, or VTA, right to the nucleus accumbens. When nicotine binds to the alpha-4 beta-2 and beta-2 nicotinic receptor subunits, boom, you get a massive rewarding release of dopamine. That dopamine spike is what drives the reinforcement. When you cut that supply off, the brain panics and the patient experiences severe withdrawal and impaired psychomotor function that can last for weeks. Okay, moving on to section 2, nicotine replacement therapy, commonly known as NRT. The strategic goals of NRT are pretty straightforward, but absolutely critical for your exams. First, we substitute the nicotine to alleviate those terrible withdrawal symptoms we just talked about. Second, we deliver it safely. It's the tar and the thousands of other chemicals in tobacco smoke that cause lung cancer and COPD, not the nicotine itself. And third, we completely avoid the rapid, addictive pulsatile delivery that comes from puffing on a cigarette, which usually rockets a sharp bolus of the drug straight to the central nervous system. For top marks, you really need to clearly contrast the kinetics of different NRT preparations. Think about it like this. Fast-acting options, like your chewing gums and nasal sprays, give an intermediate, rapid delivery. They are fantastic for crushing acute, sudden cravings. On the flip side, sustained-release options, like transdermal patches, have a much slower onset. They maintain a nice, fairly constant plasma concentration, around 75 to 150 nanomoles per liter for about 20 hours. It's basal coverage versus bolus relief. Now, I absolutely love this quote from the literature. This is a golden exam pearl right here. In clinic, patients will always ask you, "Doc, won't I just get addicted to the patch instead?" The answer is a definitive no. Humans are highly unlikely to become addicted to transdermal patches precisely because they lack that rapid pulsatile delivery to the brain. It's that sharp peak and trough of dopamine from smoking that drives the compulsive addiction, not the slow, steady hum of a patch. All right, section 3, non-nicotinic therapies. These are the heavily tested heavy hitters. First up in this category is bupropion. You absolutely must memorize its mechanism of action. It is a selective inhibitor of both noradrenaline and dopamine reuptake. Once it hits the liver, it gets converted to active metabolites like rhodopsin. We use a slow-release formulation of bupropion to treat nicotine dependence because it does a brilliant job of reducing cravings without causing any euphoria or having any abuse potential itself. Plus, it is incredibly useful, like a real game changer for smokers who also happen to struggle with comorbid depression. But you have to pay close attention to the safety profile, especially for your clinical vignette questions. Common adverse effects are what you'd expect: headache, agitation, dry mouth, and insomnia. But here is the massive red flag you need to know. Bupropion lowers the seizure threshold. Because of that high risk, it is strictly contraindicated in any patient with a history of epilepsy or seizure risk factors. Oh, and it's also contraindicated in patients with a history of eating disorders. Don't forget that one. Next, we have varenicline. Listen, if you only memorize one single mechanism of action from this entire explainer today, let it be this one. Varenicline acts specifically as a partial agonist at the alpha-4 beta-2 nicotinic acetylcholine receptors. This mechanism is just beautiful pharmacology. Because varenicline is a partial agonist, it provides just enough basal stimulation to reduce the terrible cravings. But it also sits on that receptor like a physical lock. So if the patient relapses and smokes a cigarette, the receptor is already occupied, blocking that full euphoric dopamine reward. It's highly effective. However, note the serious adverse effect. It has been linked to suicidal ideation. Now, I've also thrown mecamylamine in here. It's a pure nicotinic antagonist that completely blocks the effects of nicotine, but due to severe systemic side effects, it's rarely used in primary care. Moving right along to Section 4, Cessation Strategy and Counseling. Because, let's be real, drugs don't work in a vacuum. The absolute gold standard clinical protocol involves pairing short-term pharmacotherapy directly with active behavioral counseling. You help the patient set a hard quit date. You initiate your NRT or bupropion to manage the brutal physical cravings, and then you monitor them closely for the first 2 to 3 weeks. Why that timeline? Because the acute physical withdrawal generally subsides after a few weeks. But the psychological dependence, that can linger for months or even years, which is why that behavioral support and relapse prevention strategy is absolutely crucial. Okay, we've made it to Section 5, the master table and exam pearls. This is the money section. I want you to literally take a mental screenshot of this matrix right now. If you're tackling a 25-mark long answer question, laying out your response just like this, with the drug class, specific agent, mechanism, and adverse effects clearly tabulated, will absolutely guarantee your top marks. We've got NRT providing sustained substitution. We've got bupropion inhibiting DA and NA reuptake, but watch out for that seizure risk. We have varenicline acting as our partial agonist, keeping in mind the suicidal ideation warning. And finally, mecamylamine acting as an outright antagonist block. Now, when the examiner decides to grill you with rapid-fire questions in your oral viva, you need to be ready to fire back without missing a beat. What's the primary pathway? Mesolimbic dopaminergic, VTA to nucleus accumbens. Boom. Why use a patch? It provides non-pulsatile sustained kinetics. What's varenicline doing? It's a partial agonist at the alpha-4 beta-2 receptors. And when do we never, ever use bupropion? In patients with seizure risks or eating disorders. Let's lock this core triad in one last time to make sure it sticks. NRT substitutes the drug. Bupropion inhibits the reuptake of dopamine and noradrenaline. And varenicline partially agonizes those alpha-4 beta-2 receptors. I'm going to leave you with this final, somewhat provocative thought to ponder as you hit the books tonight. Think deeply about varenicline. How does partial agonism perfectly position a drug to simultaneously feed a baseline craving, yet structurally block the explosive dopamine reward of a relapse? Truly understanding receptor kinetics is the ultimate key to mastering pharmacology. All right, thank you so much for joining me for this explainer. Study hard, and I'll catch you in the next one.